This is a patient with kind of like a malignancy in their staging. Um, the finding is not related to the malignancy, just a foreign object,
Oh, I see
which
something in the vagina that looks
yes, yes, right
like
Is it like
here.
the queen of the chess?
It's a what?
Like it, what shape is it?
oh, he's
Oh,
saying
a
it's
chess piece.
like a chess piece that looks like the queen.
It does look a little bit like a chess piece, yeah. So my colleague Maria Zulfikar shared this with me, and I've never seen this before. Any guess as to what it is? No? Okay, well, I guess everyone has already guessed. So this is a Poise Impressa. Okay.
What?
Can you see my screen?
Yeah,
So this is a Poise, or Maria found out
like a
this is what
tampon.
this is. What?
Is it a
It's
type
like a,
of tampon?
yeah, but it's actually used for urinary incontinence.
Oh,
Yeah, so it's, let's see if I can pull up here. It supports, it's just patients who have urinary incontinence, like stress urinary incontinence. So it is, and then they put this in the vagina, and it just supports their bladder so that when they sneeze or, any kind of stress, Valsalva, they don't, urinate, like just urinary
so is it
incontinence.
sort of like adding additional structure and pressure to the urethra?
Yeah, yeah,
Oh,
like from
cool.
posteriorly.
Yeah, yeah.
So then interesting, I found out it's you put it on for 12 days or 12 hours. You take it out like a tampon, I guess. Um, and it's not reusable. So, I mean, you're like going through a lot of this, you know? Um, so it's
It
interesting.
kind of reminds me like it's sort of like a temporary, the same thing that like a urethral sling does, which is like pulling the urethra, like putting pressure on it to pull it forward,
Yeah,
but without having to undergo surgery, which you could have complications from.
right, right.
Very
So it's
cool.
it's like another type of like a pessary sort of to support the pelvic floor.
I'm wondering what would be the use of deflux in these cases. Deflux injections.
I'm sorry, deflux?
Yeah.
Like a urethral injection. That's also used
Oh,
for continence.
Bulking agent.
yeah. I mean, maybe the patient doesn't want it, right? Like it's non-invasive, completely non-invasive. Uh, so I mean, I guess it's less invasive than a suspension.
Yeah.
Um, and this is completely non-invasive, so probably just, degree of symptoms and like how much it bothers them, quality of life, balance of those.
The So the two images at the top are current image, and we have two priors at the bottom. Starting with the current image,
Can you just make it a little bigger? Like, can you double click to blow up on it or? Okay, perfect.
so this young guy comes with pain in abdomen, and the history has been since like couple of years, and it is on and off. So this is during one of his episodes he comes, and we see a lot of stranding around the transverse colon, and we see colocolic
Oh,
intussusception.
intussusception. Yeah. Is there a lead point?
We tried so hard to find a lead point, and plus he's an adult, so we should be usually finding one, but we did not find anything. Other than what we see here is just edematous mucosa, edematous wall. And again, that can be just just an effect of intussusception. So this guy also had been scanned at our facility at least 3 months back, and he had intussusception at the same place. And he had an additional finding, which was edema of the terminal ileum, cecum, ileocecal junction.
The hepatic flexure looks a little thickened too.
Yeah.
Yeah, so it looks like a colitis picture. And when we think about like TI, you can think about like Yersinia, Shigella, TB.
I'd put the ischemia in there because of the age.
He's 30 plus.
Oh, he's young. Oh, interesting.
And it's recurrent, and This
Runner's
position,
ischemia, runner's colitis. I just learned about that from Karen.
and this
Is he a
was
runner?
reduced. Sorry,
Is he a runner?
no.
Oh, okay.
And this was reduced under fluoro, and just showing you a fluoro image, and that's what we see, like a lot of submucosal edema. So basically, this patient was HAE, hereditary angioedema edema. So it was just like during moments of stress, he would just have angioedema edema, like we have when somebody takes antihypertensives like ACE inhibitors, lisinopril. So even without taking, the patient underwent those episodes of stress, developed edema, and that edema acted as a lead point for colonic intussusception. And then
Is
he
it a
was
genetic disorder? Like
Yes.
what causes? Oh,
Yeah, it's a
wow.
genetic disorder, and then he was put on C1 esterase inhibitor, and that led to resolution, spontaneous resolution of during this episode, and then after this, he's been on maintenance dose for that.
Sorry, what's the mechanism behind the medication?
I will pull that mechanism. Just give me a second.
Oh, that's okay. I mean,
So just so I understand, this was stress-induced angioedema.
This was like it can stress can give rise to angioedema, can precipitate episodes of angioedema, but this was basically hereditary angioedema edema, and he was lacking the enzyme C1 esterase inhibitor. Do you guys see my PowerPoint?
yes.
Yes.
So basically, this was absent, and the final common pathway is this increased production of bradykinin, and that leads to edema, vasodilation, and pain. So this guy had C1 esterase inhibitor deficiency, and the same mechanism, but from the other end is when we have ACE inhibitors, especially lisinopril, and they act on the same pathway, and then we have excess production of bradykinin.
Wow.
That's cool.
Really cool. I've heard of it. Amazing.
Wait, so the mechanism, like how does it help him? Like the meds? Like where does it intervene in this pathway?
It intervenes here. So when it intervenes here, so the kallikrein is produced in excess because it is not being produced in this state, and then excess bradykinin is not formed. So we are intervening at this state.
Wow. Imagine if like any of us had it. I mean, we'd be like having intussusception every day.
Well, you know, it's interesting. Like I've had people tell me that when they have to speak in public or they get stressed out, they literally get
absolutely.
GI symptoms and GI illness, you know, and like we're not imaging them, but they could be having like edema or, you know, ischemia or whatever, you know, like.
And what was most interesting was like, I had not known that just to the images that I showed you, there was edema, submucosal edema. So even submucosal edema can act as a lead point. And this is probably in conjunction with two cases which you guys had shown, I think, many, many months back. One was typhlitis, and because of neutropenic enterocolitis or typhlitis, and because of so much edema, the colon had undergone intussusception. So even the lead point, even without a actual lead point, just edematous colon can act as a lead point.
For ACE inhibitor angioedema, I mean, I've usually seen it more in small bowel. This one seems to be recurring like in the colon, the right colon and transverse colon.
I mean, I did not find any literature saying that what is the most common site. Yes, ACE inhibitor is most commonly jejunum and ileum, but I did not find anything for this.
You should publish this. I mean, I know this is just a common entity that we're aware of as a case report.
Yes, this is very cool.
Is this this is a patient whose status post nephrectomy for RCC, a couple of postoperative seromas here. And this was a really, well, let me just show you, and then we'll get to the findings. The findings here.
I was like, why are you just perseverating on the test? I mean, can you scroll through that hernia?
Hernia? Did you say hernia?
Yeah, right now I just saw the potential hiatal hernia, but can you scroll through back?
Oh,
Okay, wait, and scroll back down slowly. For some reason, it's just like staying in that one area for me.
that's all there is. That's all there is.
But can you scroll
so-
back, scroll down?
Scroll down. Scroll down. It's not GI. I'm not looking at GI, looking at the lungs.
Oh, got it.
Okay, well, I would not have picked this up, but AI did. And then if you look at the thins, you're like, oh, there is a PE.
PE, yeah.
I know, right?
Oh, wow.
Right? So, and it actually happened a couple of times. Like I'm like, oh wow, that's a great pickup. I don't know that I would have called it, and I only really appreciate it on the thins, not on the the 3 millimeters. Right? Look at this.
Yeah, it is not seen only on like thicker cuts.
So this is a great pickup from AI.
The question is, I mean, sometimes when they're small and peripheral, they don't treat them.
Okay,
So
well, it
is AI
doesn't
gonna pick
matter.
up too many.
It's important for them to know this. Oh, but it's possible. Yes, I'm like, you guys are going to be good, right? It doesn't matter if it's 2 a.m. or whatever. They're going to pick up all of this, and I think it's a good thing. It's a good thing, right? Like it's not bad. So
One of my old, colleagues from chest firmly believed that this is a bad idea to find out. Like, she felt that we were too sensitive for these insignificant pulmonary emboli. Would create more damage than good.
I don't know. I don't know.
That's what she do. I don't know if I agree with that.
Yeah.
And probably from medical legal point of view, it's not correct, but she
I do
has a
think
point that
Yeah, like we could potentially be over treating these. This is like, sounds like a good problem for Matt Davenport to solve. Like the fact that he showed us that like we're over treating or we're over pre-steroid prepping people, and it's actually, there's a huge cost to it. So good point.
I'm not a PE expert, so I can't really make I don't know. But I do think we'd pick up too many IPMNs. The little 2-3 millimeters IPMNs that we follow like forever.
Agreed. So I think I showed this case before, but just to remind us, there was this little swirling here, and there was a mass here. The mass appeared intimately associated with this small bowel loop.
Good
With some
gist.
air in it. Yeah, so the question became like, is this aneurysmal
I don't
dilation
know.
of the small bowel loop? Like, is this a lymphoma, or is this like a gist that has, sort of eroded into the mucosa? And we actually did get a MRI that was kind of helpful, that just kind of showed, it's frankly communicating here, but it's very heterogeneous, which would be really atypical for lymphoma. Has areas of necrosis in it, and it didn't seem to have any bowel loop coming back out of it. So anyway, this was resected, and this turned out to be a GIST tumor. So that was.
Do you have the diffusion?
Yeah, just show you again that this is and basically it had like frankly eroded into the mucosa, so there was like succus and air going into the GIST. But that isn't necessarily a malignant feature, but in general, small bowel GIST do worse than gastric GIST, and especially as they get larger. You wanted the diffusion. Yep. Here is. So there was some.
Lymphoma restricts a lot. I mean, probably more than just,
Mhm.
but sometimes you can't tell. Yeah.
Yeah, this is confusing. It's very heterogeneous, so I
Yeah.
think it's confusing in this case. But anyway, it was resected and it was a GIST. And then hold on one second, I'm just going to pause. Okay, go ahead.
In fact, GIST rarely can show aneurysmal dilation, and it can be indistinguishable, at least on CT, from lymphoma. And interestingly, the aneurysmal dilation is classic for lymphoma, but not pathognomonic. And adenocarcinoma of colon can also show. And if not today, maybe next time I can show you those two cases of aneurysmal dilation of colon because of adenocarcinoma and of small bowel because of GIST.
That'd be
Yes.
great. Yeah. Okay, here's a companion case. So we had this piece of small bowel that had this kind of thickening that went into this mass that also had an air fluid level in it. Looked very similar, don't you think?
Yes.
Yes. Okay. So so we were like, oh, this could be a GIST. This looks just like the other one. Maybe it's eroded into the mucosa. Then they had these like weird nodules in their abdominal wall, which didn't really look like injection sites. They looked like true nodules, which was weird. And then they had this liver lesion, which looked suspicious. And then they got a PET.
Wait, can you go through liver lesion one second? I'm sorry.
Uh-huh.
Okay.
Okay. So then they got a PET. And the PET was read as that this mass was very avid. The liver lesion was not avid. This was an outside PET. And one of my teaching points actually is that, you know, you always kind of just, if you think something doesn't line up, you know, reanalyze it. So we still thought that the liver lesion looked suspicious on CT, but they didn't really call it on PET. So we had our PET people look at it again and they were like, well, and this is the thing, like they send over these screenshots. So it's not like you can even really window it or know exactly what's going on. So our nukes people uploaded it into our system and they said, you know, actually there is definitely something right there. Right there. So it's not as avid as the pelvic thing, but there is something. So they ended up biopsying this. What I didn't tell you is this patient has a history of multiple myeloma, and this was all plasmacytoma. So there was, so when you have aggressive myeloma and you see like weird masses elsewhere, always think about extramedullary disease and plasmacytoma. So both the bowel thing and the liver thing, and then we haven't biopsied the abdominal wall stuff, but I think that those are probably also plasmacytoma. So yeah, it was just a interesting one. I guess plasmacytoma to me can always look like lymphoma and it can basically be anywhere. So just always think about it when somebody has myeloma. And it can be like pretty rapidly progressive. I've seen like perinephric plasmacytoma be pretty rapid. So
I'm just so that's like massive aneurysmal dilation of one of the small bowel loops.
that's crazy. It looks like colon. There's so much. Whoa.
And I always thought of it as a lymphoma, but then it came out as GIST. And I have similar dilation of colon, which I'm not finding right now, and that came out as adenocarcinoma. In fact, like almost 95% tumors of large bowel are adeno. So statistically, whatever pattern it presents with, it has to be adeno in large bowel.
I have a question about this one.
Sure.
Is this truly aneurysmal dilation of the small bowel, or is this just a huge mass that has communication with the small bowel and therefore that has air in it?
That's a good question. Again, we do not have serial follow-ups to see if it was like small to begin with or if it was big to begin with and just cavitated with the small bowel. But it looks like it is, like if you see, this is sort of normalish looking bowel. So less likely to be like eccentric and then it just cavitated with the bowel lumen. But I think that's a good point. That's a very good point.
Yeah, we'd need sort of the pathologist to tell us what's the wall there, you know? Because GIST generally doesn't grow as like a circumferential tumor.
Yes, and in fact, I looked it up on there is an article in AJR and where they describe a similar appearance for GIST. Let me see if I can find that article. I mean,
okay.
Let Dr. Tan discuss another case and let me see if I can pull up that article.
Okay.
this patient presented with flank pain, right flank pain. No obstructing renal or ureteral stones. There's pelvic cysts, parapelvic cysts. The finding was in the liver. And let me give you the axials. So there's these like low attenuating, hypoattenuating regions in the left hepatic lobe that was picked up. And I thought that was a really good pickup, which right here, probably see it better on the coronals here, right there. So then
Are they going along the bile ducts?
Why
do we see something in the middle of them?
it's here. I don't know that I see any kind of biliary dilil. Okay, so then they got an MR. This is what the MR looked like. Right there. And then here's the T2 right there, these little cystic stuff with T2 intermediate kind of signal. And then here's a post.
So far I'm thinking abscesses.
Good, yeah. So and then diffusion. Let me give you the diffusion. Here's ADC. Actually, it's not. It's hard because of the location. Let me put them side by side. Oh, it's hard. It's hard to see. Yes. So that was, and then so it's left-sided. Kind of there's stranding, inflammation, rim enhancement, T2 cystic, centrally, fluid signal. And if you look at the CT, where's the CT? There's some colonic diverticulosis with a little bit of thickening, but without itis. Over here. So maybe a little bit of like chronic diverticulitis, there's a little bit of maybe muscular hypertrophy. And the read was that, maybe it's seeded from the colon into the left liver through this pathway. So this was a paper written by Steve. Pileophlebitis through these portals past bad bugs, excuse me. And there's distribution of abscesses depending on where it's coming from. And there's a great diagram here, cartoon. So the sigmoid, like the vein empties from the IMV and goes in the splenic vein, and it preferentially goes into the left hepatic lobe. Whereas things like from the right colon and colon will drain through the SMV and then go preferentially into the right hepatic lobe. And this patient had sigmoid kind of diverticulosis, thickening, kind of chronic diverticulitis. And the presumption was that perhaps that was what was kind of seeding into the left hepatic lobe, causing those little tiny abscesses in the left hepatic lobe.
That's really interesting. Because I've always learned that you get more abscesses in your right lobe. And I thought that was because like your SMV is flowing more to the right, which is what this diagram is showing. I never really thought about the IMV getting influenced by the splenic flow, because, and I think this would actually, it would depend on where IMV joins these structures, because sometimes the IMV joins right at the SMV splenic confluence, right? Like it doesn't always join over at the splenic vein. Right. So depend where it joins, but this totally makes a lot of sense, because I think, like maybe, because actually most things will come from, sigmoid diverticulitis, right? But we still get most abscesses in the right lobe. But I could see if you had this like IMV that's further out, then it would go to the left.
That's interesting. One of the things is right lobe is more susceptible for all of these things. A, because of it is bigger in mass, so it drains more blood. And this streamlined pattern is also applicable when there is amoebic colitis. So one of the favored locations for amoeba, entamoeba histolytica, is cecum and ascending colon. And that's where most of the most of the infections from there go to liver, so they go to the right side of the liver.
Definitely.
I found the article on aneurysmal dilation. Let me just share. Do you guys see the screen?
Yes.
So that's the example they show. And what Dr. Sekhar said, that's right. It says this may partly be because of the cavitatory nature of these fast-growing tumors.
Cool. But that example does seem like it's generally kind of sort of communicate. I guess maybe it doesn't really matter if it's like, I still think even though they say aneurysmal dilation of the bowel, that whole thing might just be tumor that
Yes.
has a cavitated center. But thank you for the example.
Sure.
Okay. So this patient, I'm withholding some history, but what do you guys think?
Peritoneal dialysis catheter.
Uh-huh. So there's peritoneal dialysis catheter, and then there's fluid in the abdomen. Oops. Anything interesting about the fluid?
It is normally hyperdense. I mean, like if we are doing peritoneography, then it is going to be hyperdense. Are we doing peritoneography or?
Yes. So normally it should not be hyperdense. Normally it should be like simple fluid kind of. But in this case, we injected dilute contrast. So this is CT peritoneography, which is a kind of rarely used technique. And I'll explain some of the reasons why they use it. And in this case, we did it because this patient was having bilateral hydrocele that would kind of get bigger whenever they would get their dialysis. And so they wanted to see if these were communicating hydrocele. So I didn't know there's two different types of hydrocele, a communicating hydrocele and a spermatic cord hydrocele. And then the spermatic cord hydrocele, there's two subtypes called encrusted and funicular. But the main thing is that, the communicating type is like people who have ascites and then have a patent processus vaginalis that can go and contribute to a hydrocele. So in this case, we could see there's a little bit of hyperdensity along the spermatic cords, and there's hyperdense fluid in these hydroceles. So these are communicating hydroceles. That's the reason they were getting bigger during dialysis. We've proven it now with the CT peritoneography, and I guess they'll decide what they want to do about that. But I thought it was interesting because I had never read a CT peritoneography exam. So I looked it up, and basically they do this. They used to do it more probably a long time ago. They sometimes do it in children, in infants, to see if they have a undiagnosed hernia or a patent processus vaginalis, although most infants it will resolve. But they often do it in patients who have peritoneal dialysis with complications. So if there's a leak, if there's a leak along the catheter, along prior catheter sites, or if there's adhesions or loculated areas, like if the peritoneal dialysis is not working well, you can use this to sort of outline and see if they have like a lot of adhesions in their abdomen, if they have loculated areas that are not communicating with the free flowing, and then to look for hernias. So umbilical hernias, inguinal hernias, etc. So I just thought it was interesting because I had not come across this before. There's some chat. Oh, Victoria is saying she has to go take an ER case. Okay, I'm going to pause. Yeah.
Sometimes it is peritoneography is done to see if there is pleuroperitoneal fistula or communication.
Yes. I found one paper that was like all about that, and they said that they were able to prove communication between the peritoneum and like a chronic pleural effusion from this study. So great.
Okay. So this is a patient who had a ureteral stent placed, has like known history of neuroendocrine cancer of the bladder. and had stent placed for obstruction, malignant obstruction. So you can see the mass here, and then there's a stent. The stent looked like, normally we just see a single coil, right? But here I was like, why are we seeing like multiple coils here? And I thought maybe it was like was it a nephroureteral stent? But there's not a nephew, nothing coming through the right flank, and then I'm like, are there two stents? And no, there's just one stent. And so then I found out there's this type of stent. Let me share this out really quick. This is called a quadricoil stent. Sorry, I should have here. Maybe I'll just put it here. Can you see my screen? So it's a quadricoil stent, and it has more than one coil. So it's useful because it can, like, sometimes it can uncoil or it can migrate. And I get the thought is that if it has multiple coils, then those are less likely to occur, those complications. So this is a quadricoil stent. And so it has like a loopy loop, yeah, right there.
I was gonna say, Nelly, when you were scrolling through, I was wondering if you could connect all of it. So you can connect all of it. It's
Yes,
not like
I was able to connect them.
Right.
Like, that's a weird looking stent. And it's because it's a quadricoil stent. Yeah.
I guess I would have just thought it was like sort of redundant in there, but not purposely a double coil, but that's really cool.
Yeah.
So we have current studies at the top and newer studies at the bottom. This is a young female, and she came with complaints of abdominal pain in the right upper quadrant. Sorry, I can't.
Can you double click on that?
Sorry. Yeah, so she came with complaints of right upper quadrant pain, and there was absolutely nothing going on in the abdomen, except we saw these few hypodensities in the subcapsular region.
And no pelvic inflammatory changes, right?
That's a very good thought.
Oh, she has a diva cup.
Yes, and just to bring things to perspective, so we see them like very well in the subphrenic, subdiaphragmatic space. She had an IUD, and we knew that she was sexually active. So we were thinking in terms of Fitzhugh-Curtis, or maybe like, one very extremely remote possibility of, can this be actino or something? She had a recent history of travel from Dominican Republic, and I'm not sure if a lot of you guys know that Dr. Sekhar was here at University of Iowa, and she was talking about cool cases, and she did mention about fasciola hepatica. And it is different from other liver flukes because when it goes to duodenum, instead of going to CBD, biliary tree, directly through ampulla fata, it goes outside and attacks from Glissen's capsule. So we gave that also as a possibility because of the recent history of travel. But interestingly, all was negative. Like there was no eosinophilia, and it was not fasciola, and there was no actino, none of that. And 2 months later, she gets an MR done, and MR is pretty impressive.
Ooh, is it endometriosis?
Yes.
Yes. Oh, look at that.
Wow. Nelly, you showed a case just like this where I went to the
Oh, yeah, it was incredible. And I can pull it up because MRI underestimates. It's like the tip of the iceberg. You see a little bit, and there's a lot here, but there's gonna be a lot more intraoperatively.
Wow. And did she have any known endometriosis? And did you see any in the pelvis on the MRI? Or
No,
like,
nothing in the
included the
pelvis.
pelvis?
Nothing in the pelvis.
Whoa. Cool. The power of MR. Now I'm kicking myself, like maybe we should have thought of that too. What do you
I don't think I would have ever thought
CT?
about that.
You know, so anything can go, like the peritoneal cycle likes to push things and up that right upper quadrant and then between the liver and the diaphragm. That's actually how endometriosis gets to the right lung base and causes catamenial pneumothorax.
Mhm.
But wow, okay,
In
cool.
fact, is it sigmoid volvulus?
You tell me.
Um,
Can you show
looks
the
like
coronals?
bound.
This should remind you of something.
It looks like a giant kidney.
Yeah,
Oh wow, okay.
this is the coronal. I can't even get the whole thing. Let's see. Right? So yeah, this is a massive hydronephrotic kidney from chronic UPJ obstruction. And you can see that the colon is pushed over here. And so it looks like a retroperitoneal structure because it's pushing the left colon up. And it's got, like, my residents were like, oh, it's haustra, you know, but it's not really, because it's not going all the way across, it's only in the outside. So these are these massively dilated calyces, and there's no left kidney, and there's vessels, there's the renal vessels going into it. So yeah, the biggest kidney I've seen, the biggest non-functioning kidney.
So this is a patient with a known history of endometriosis and got an MR, companion case. So on the MR, you can, it's really subtle, but you can see them. These little dots, T1 hyperintense signal here along the subdiaphragmatic space, right there, right there. And actually there's more than that. There's a little bit there. There's a little bit there, anterior in the Morrison's pouch. And this is like what it looked like intraoperatively. Like it was everywhere. Like all these little black dots, those are all endo, like everywhere. And these little dots here, these spots, so once you see a little bit, there's a lot intraoperatively, and MR underestimates it. But if you see it, it's important because, like this patient, they resected the diaphragm, and cardiothoracic surgery got involved intraoperatively to do the kind of the excision on the diaphragm and do the diaphragmatic excision and subsequent repair. So it's really important to note this, and when you see it, and it's hard to see, so you have to really have high level of suspicion for these findings. And I think the FATSAT T2 is really helpful because you can see these little hyperintense fluid signal. In fact, I feel like you see it better on that FATSAT T2 than you do on the T1, FATSAT T1s. But you see all these little fluid, right? So the minute you start seeing this stuff around the capsule, like endometriosis, it's a woman and pelvic pain, it has to be on your differential. And I think FATSAT T2 is incredibly helpful to look for diaphragmatic disease. I think these are all part of the endometriosis, these little T2 hyperintense dots. So
Great companion case. What do you think about this high KUB?
Oh, what is going on with the enteric tube?
Yeah, what's going on?
Does the patient have like situs?
No, I don't.
Pneumothorax.
Yeah, no, maybe it's just malpositioned, like
Yeah,
into
it's
the right
malpositioned.
bronchus.
It's in the right
Oh,
lung.
and they poke through the pleura and then cause the
There's
pneumo.
Yeah, exactly,
Oh,
exactly. So
wow,
this
July.
is
July.
first, like I've never seen it go this far down, but anyway, usually you see it out here, but this is just kind of out in the pleural space, right? So and it did and you can see this edge of the lung here, so pneumo, and you can see the pneumo a lot better on the chest x-ray. So it was also interesting, like how much better how much, so, you know, in the abdominal x-ray, we're focused in the abdomen here. So we kind of over penetrate and like, we're not focused on the lung, but don't forget to look at the lung and make sure you look for a pneumothorax.
With history of like prostate cancer previously with like pelvic radiation for prostate cancer, and now has complication from radiation. You know, radiation is not benign. It's and you know, the complications are delayed, but when they occur, they can be pretty significant, like this case. So patient there's a lot going on. Maybe, I don't know if the
Fistula between colon, prostate, bed.
Yes, yeah. So this is their colon right here, the rectum, and there's a frank fistula communicating. I mean, this is basically a necrotic prostate bed, and with a huge, you know, just fluid collection. It's eating away at the bladder. There's osteomyelitis of the pubic symphysis, and just drainage, you know, through the perineum here. It's like start to, you know, the cavernosum is infected, and it's basically just, you know, now probably just all infected stuff. And the only really effective way to treat this is just pelvic exoneration. You know, they have to divert the stool and divert the urine, and it's a big surgery, but that's the only way to really effectively treat this, and you know, help this patient get better. But it's a very morbid surgery, you know, and these patients are usually older men who are frail. So it's yeah. So just,
Yeah,
you know,
this is a very dramatic case. Do you know if they did external beam radiation?
yeah, they said pelvic
like they did.
radiation. It was remote, you know, and in the I think before they used higher doses, and you know, it wasn't as localized, it wasn't as kind of limited. So, and probably the doses are higher, things like that. So then that's the damage is just a lot more severe.
There's one interesting thing I want to like not talk about the case, but about the treatment part. Sometimes when they do pelvic exentration, so there's a lot of empty void. So that can be a cause for bowel to prolapse and cause herniation and obstruction. So I was at AUR meeting last year, and they had shown a case in which they had put breast implant inflated in the pelvis to fill that dead space.
Oh, wow.
Wow. Our surgeons often do like, mental pedicle, like a pedicle flap.
Mm-hmm.
But we've seen complications with those too. Like if the vascular supply gets compromised, they can become necrotic. But yeah, otherwise, yeah, it is a big space. We often, I feel like in this case, our surgeons would often do first they would divert the colon just to stop that flow of stool into the area and try to like cool everything down. And then if it cools off enough, then maybe try to resect it.
Okay, I have another case. Call case. Patient came in with, is it recording?
Yes.
Okay, great, sorry. Oh shoot, let me move the arrows. Abdominal pain.
A lot of standing in the right colon at the cecum base. Cecum.
Okay, good.
Appendicitis or something like that. No. Divertic. I see standing around diverticular.
Here, right? You're saying here?
Oh, like small bowel diverticular?
Here, let me take you back here. So here's our ileocecal valve, the fatty. The TI is here, and then the appendix is
Oh, and there's an appendicolith
appendiculith, yeah.
and like perforated appendicitis.
Yeah. So this is what it was. Perforated appendicitis. And there's an incidental finding as well.
Is there a nodule in the duodenal bulb, like a neuroendocrine tumor?
Yeah. Everything was like, so I said there's a duodenal mass, or like there, and I said this looks like a perf appendicitis. I chatted with um the ED doc, and the ED doc is like, oh, I'm looking for dilated small bowel, and that's why I did non-con. And I'm like, no, you need contrast.
This is like apropos of our discussion we just had.
Yes, yes. And so we chatted about why contrast is really helpful. So, um, so then got a contrast, and GFR was, not great. It was 50, like 55. So it's not great, but it's not too bad. And there is indeed a lesion in the first portion of the duodenum, the duodenal bulb, and then we see the perfect appendicitis, which I think you can, the diagnosis you can also make on the non-con. So, and this was indeed a perf appendicitis
Catch on the
operatively.
duodenum.
Yeah. That hasn't. Oh yes, thank you.
Okay. Finding is on this image.
Some mass posterior to second portion of duodenum.
Yep. So
What
there's
is
a mass here. So what would you give as your differential? I can show you the coronal.
It looks like it is going inside the eye. I mean, is it extending into the IVC? Yeah.
So what do you think it could be?
Leiomyoma of the IVC?
Sorry, what?
Leiomyoma of the IVC?
Okay. Leiomyoma of the IVC?
Leiomyoma or leiomyosarcoma of the IVC?
Okay. Good. So, excellent. So it was brought up like maybe it's a GIST tumor, which I think is also appropriate for the differential, because it has this interface with the duodenum. So it could have been an exophytic GIST tumor. I think that's reasonable. But as you noticed, it is like, you could say, is it invading the IVC? But actually, you could also say, is it arising from the wall of the IVC? And many leiomyosarcomas look like this, where they're sort of exophytic. And even though they arise from the smooth muscle of the wall, they grow outwards like this. So sometimes people don't recognize that it's actually just arising from the actual IVC. So anyway, this was resected, and this was an IVC leiomyosarcoma. And I think we should, especially because it's heterogeneous, we should put that above leiomyoma. Leiomyomas are usually smooth and kind of oblong, and this one's more heterogeneous. And because we have this nice IVC phase, we can tell our surgeons, this is the interface with the IVC here, and they were actually able to cut it out and put a graft on the IVC and save the IVC. So they had enough IVC there, and they were able to save it. So.
Is it also involved in the gonadal vein? I think I see some twig of vein going at 5 o'clock. Yeah, that one.
Yeah. So actually, it's interesting that you say that too, because the final path basically said that it was involved with the gonadal vein. So we don't actually know the true origin. Like, did it start at the IVC or did it start in the gonadal vein? So that's a great point. I don't want to complicate things, but excellent observation. So, yep.